Okay, so continuing on here, the video processing thing that I'm using only allows for 30-minute takes. So I was here to test reliability. So that is the degree to which the same respondents have the same score after a period, and when a trait should not have changed, the GAT-7 shows good retest reliability. Criterion validity is the extent to which a measure is related to an outcome. GAT-7 is a useful tool with strong criterion validity for identifying possible cases of generalized anxiety disorder. Construct validity is the degree to which a test measures what it claims or purports to be measuring. Lowe et al. Substantiated the one-dimensional structure of the GAT-7 and its factorial invariance for gender and age. Concurrent validity of a measure correlates well with a measure that has previously been validated. The GAT-7 yields significant intercorrelations with the PHQ-2 and Rosenberg self-esteem scale. And then convergent validity. It's the degree to which two measures of constructs that theoretically should be related are in fact related. Higher GAT-7 scores correlate with disability and functional impairment. Measures such as work productivity and healthcare utilization. Okay, so just a few more slides here. So I want to talk a little bit about GAT-7 being integrated into an electronic health record. So EHRs are pretty much standard practice in healthcare settings, whether that's a hospital or recovery center, or just a behavioral health organization. I worked for JAMI, which is a behavioral health organization here in Juneau that used CareLogic. CareLogic was the system that I was familiar with. And essentially what an EHR does is it gathers all of the information that is necessary to successfully treat clients, from treatment plans to assessment data to just like personal information about the client, sometimes like clinician notes, things like that, case management notes, and so EHRs are accessible by the staff that work for the organization, and so multiple staff members have access to clients' information, typically based on caseload. So, for example, when I was working for JAMI, I had 26 clients on my caseload, and I had access to all of their information. It was, for confidentiality purposes, pretty standard practice that I only have access to my own clients. And so typically, even though CareLogic had probably hundreds of records, of client records, I was only supposed to access my own clients. If I were to try to access a client that was not on my caseload, I would get flagged, and the privacy officer would ask, like, why are you looking into this person? So it's not like social media where you can just look anybody up and just find out what their diagnostic information is, find out if they've been to, say, the NHU, find out if they have criminal history, because it's a lot of very personal, highly personal information. And so the GAT-7 is easily integrated into an EHR. This is an example from Novapsych. It is a different EHR than what I use, but the procedural stuff is pretty much the same. So the way that it would work is, say for example, a client went into a primary care office for just a checkup. At the start of it, they'd be given several forms, one of which could be the GAT-7, and they'd fill that out. And so it would be the receptionist's responsibility to input that information into the EHR. And so that's what you see here. From this score, you can see what the person scored was a 3. So it's the severity is none or minimal. only took 24 seconds to do. And of course, being that it is 2025, some of this information could potentially be done through a computer or an iPad, just kind of depending on the facility that the person is going to. But nonetheless, it could either be done on paper and then input into the system, or just done on some kind of electronic device, and then transferred over pretty easily. And so the beauty of that is you would be able to track progress over time. And so that is very helpful when thinking about interventions, when you're working with clinicians that are, placing certain interventions based off of the client's treatment plan and, where they're at. You can see okay, so we're taking walks twice a week, mindfulness walks. That's an intervention that we're using along with talk therapy. And over the last 6 weeks, this number, let's say this number was higher up here. Over the past 6 weeks, this has dropped from 15 to 12. And, you can see that progression just over time. And so when the GAD-7 is put into an EHR, it is fairly easy to monitor and track progress. Most of these EHRs have information about the assessments that they're using that is embedded into the system itself. And so this example here from Novopsych, you can see scoring and interpretation information. This link here, if I were to click on it, this is a screenshot, but had I clicked on this, it would have given me more information about the GAD-7. And it just tells a little bit about the percentiles and what the scores mean. And so that's continued here and just gives some good statistics in terms of scoring. 11% of individuals under 30 fall into the severe anxiety range, whereas 1.4% of people over 70 have scores in that range. So just good statistical information that can help guide just sort of clinical discernment, or what you're gonna do with this information. Because I think is really what these screening tools are for. Is you take these screeners, and then it's what am I gonna do with that information? And typically we need to either, if they already have a diagnosis, we need to potentially change a treatment plan, or we need to change an intervention, or refer them to a specialist, just depending on their scores. Again, if some of these things, say for example, they were at a 15 and there was no change, then those interventions potentially aren't working, but they're also not working. So just things to consider. Okay, and then here again, this is what the client, this pretend client, would have answered on this GAD-7 test. Very simple, just Likert scale. They would have just gone and clicked, boom, 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 and it would have scored immediately. All right, so some limitations. The GAD-7 scale focuses on only one anxiety disorder, although there are many patients with other anxiety disorders, such as social phobias, post-traumatic stress disorder, who need clinical attention. However, GAD is one of the most common mental disorders seen in outpatient practice. The GAD-7 provides only probable diagnoses that should be confirmed by further evaluation. So because of its simplicity, it is useful as a progress tool, but by no means is the GAD-7 a diagnostic tool. And so essentially, if a person had not been diagnosed yet and they went to the doctor, or they went to see a behavioral health organization and they took this and they scored somewhere on the severe side, 15 to 21, then they would be recommended to have further evaluation and probably have a more extensive assessment to possibly diagnose for generalized anxiety disorder. So it is limited in that sense, but it is also very useful to monitor progress. Prospective observational treatment studies are needed to determine the responsiveness of the GAD-7, assessing change across time, and then the self-report bias. So any assessment that relies on self-reported data can be influenced by the individual taking the test. And so I have seen that myself. Working as a case manager, I would attend appointments, like psychiatric appointments, with the client, and I did see a few times where the client was responding to questions on like short assessments. I remember one specifically that was on I think a borderline personality disorder assessment. It was like a quick 10-question assessment, something like MD-Calc was being used, and I knew the client, and I knew when she was responding that she was not answering honestly, and she was very smart, and I'm fairly certain that she knew what she was being tested for, and so self-reported assessments can be influenced by the client themselves. And then the other part that I did mention earlier is just the idea that depending on the culture, can determine too much worry. So too much worry for one culture may be different for another, and so that's something to consider when taking this test. It might be prudent to just take in the cultural just sort of understanding and awareness of the client. I just kind of do a little bit of digging about the client's connection to their culture and how that might sort of affect what they consider to be either too much or too little of worry specifically. And that's it. That's my presentation. Thank you all for watching. I appreciate that. GAD-7, pretty straightforward. These references, many of them, like this one, for example, this one here, Spitzer, that's a really good one. Just that's where the assessment was like when it was first made. So if you're more interested in the GAD-7, the Spitzer reference is probably the most useful, just in terms of like when they first made the assessment and how they got it put into practice. So thanks again, and you guys have a great rest of your day.